So today we're going to be discussing pregnancy at risk, the gestational onset, and this is chapter 18 in your text. So here are your student learning outcomes. There are 4 pages, so it kind of does seem overwhelming, but they're pretty specific to each disorder and symptoms and signs that go along with them. So don't become overwhelmed by them, but definitely go ahead and look through them and look at those different student learning outcomes to help you better study for the test. So complications during pregnancy. What can occur during a pregnancy that is not good? Pregnancy is typically normal and uncomplicated. However, there are cases in which problems do occur that place mom and baby at risk during her pregnancy. Complications that may arise during pregnancy are conditions such as spontaneous abortion or miscarriage, preeclampsia, eclampsia, HELLP syndrome, hyperemesis gravidarum, or hydatiform moles. So looking at our next slide, we're going to look at some causes of bleeding during pregnancy. Vaginal bleeding can occur at any time during pregnancy and is actually fairly common, but women should notify their physician of any bleeding. Some causes you could possibly see could be maybe sexual intercourse. That vaginal wall in the cervix itself is very vascular. Exercise, phenomenon of the implantation of pregnancy. You'll hear people say, I bled a little bit, so I think I had a period, but it was just light spotting. And that could definitely be what's called implantation bleeding. Threatening or an impending miscarriage that could potentially be occurring. So any spotting or bleeding observed by a pregnant woman should be reported to her physician for evaluation. As a nurse, our responsibility is to first assess the patient and see how much bleeding there is. We're going to do vital signs, check their blood pressure, pulse, heart rate, check them for temperature, just to make sure, infections can cause bleeding. How much bleeding is there? We're going to count and weigh pads to assess bleeding and save the tissue if we do see any there. Watch for signs of shock. So you're going to look for that pallor, clammy skin, perspiration, shortness of breath, restlessness, and possibly administer oxygen if needed. We're going to start an IV to do fluid replacement and type and cross for possible transfusion if their bleeding is pretty heavy. If the pregnancy is less than or equal to 12 weeks, greater than or equal to 12 weeks, then we can assess for fetal heart tones, possible pelvic exam. The doctor probably isn't going to check her cervix, but he will look at her cervix with using a speculum and doing a pelvic exam. If we haven't obtained a history, we're going to do look at her history, see what's going on, and then assess what kind of support does she have. How is she going to cope? Does she have family? Does she have friends? Who is going to be that support system during this process? So causes of bleeding, first half of the pregnancy, you're going to look at possible miscarriage or a spontaneous abortion. It could be an ectopic pregnancy. It could be a gestational trophoblastic disease or the hydatiform mole. Second half of the pregnancy, mainly the 3rd trimester, it could be due to placenta previa, where that placenta is covering that cervix, cervical opening, or abruptoplacenta. So we're going to look at spontaneous abortion, or also known as miscarriage. It's defined as the loss of pregnancy before the age of 20 weeks, or the fetus weighing less than 500 grams. Early miscarriage is usually between conception and 12 weeks. 12%, it varies kind of on maternal age, but 12% are under 20 years old, and 26% are over 40 years old. So, you're looking at younger moms and older moms both have a little bit increased risk. Many are in those very early weeks before women even know that they're pregnant. And a lot of times they just complain of maybe having a heavier menstrual cycle that month. So some women don't even know that they were pregnant whenever they do have a miscarriage. Late pregnancy miscarriage is considered 12 weeks to 20 weeks, usually caused by cervical insufficiency or maternal disease. Onset of miscarriage at this time may not be preceded by fetal death. So sometimes these babies can be born alive, and I have seen cases of, they are breathing once they have the opportunity to be born. Spontaneous miscarriage continued. So the physiological causes of a spontaneous abortion could be chromosomal anomalies, either too much or not enough chromosomes, so they're not compatible with life, and so they're not a viable pregnancy. Probably this is the #1 cause of most miscarriages, is due to the chromosomal anomalies. Teratogens, drugs, chemicals that maybe they're exposed to at work. This is definitely can be a cause. Can also be caused by a defect of implantation. If that egg did not implant properly, didn't go deep enough, wasn't able to really get into that lining of the uterus, then a miscarriage will most likely occur. Sometimes it can be related to a weak cervix or incompetent cervix, maybe abnormalities in the placenta, disorders of the immune system for mom like lupus, possible uncontrolled diabetes, hyperthermia related to hot tub use, maybe they had a high fever because they were sick, or even ecstasy use. Risk factors that increase incidence of miscarriage: one is maternal age, so a teen pregnancy or mom over the age of 40. Caffeine use, so greater than 2 cups of coffee a day. Smoking, it can affect the implantation due to the vasoconstriction that is caused by the smoking. Marijuana use has an increased incidence of miscarriages. There's not really any evidence to show that excessive exercise or intercourse or, physical activity if the mother is already exercising and doing those types of things prior to pregnancy, that stress on the body is not going to be a causation for a miscarriage. Usually they're going to present with severe cramping, abdominal pain, backache, vaginal bleeding. It only occurs in about 1/4 of the first trimester pregnancies. Sometimes, they may not even know that they've had a miscarriage, and it's called a missed miscarriage, and they may have to have a D&C or have medication used to assist them in having the miscarriage. They may have a fever related to maybe that missed miscarriage and it's becoming infectious, or weakness. So classification of an abortion, there's several types of miscarriages that can occur. So in your book, there's a table that gives you those different ones on page 294. So there's threatened. This is complaining of bleeding and cramping or backache. It could tell us that baby is in jeopardy. The cervical opening is closed, even though they are having some spotting. It could be followed by partial or complete expulsion of the fetus, or may resolve without any issues to the baby, and they may carry on to full term. Also could be a possibility, if you see that, could be a molar pregnancy or ectopic pregnancy. Imminent or inevitable, it's increased bleeding and cramping. That internal cervical os is starting to open, so it dilates. The membranes may rupture, and no parts of conception have actually passed yet at this time. Incomplete, they have bleeding with passing of parts of the materials of conception. The internal cervical os is dilated. Some of the products of conception are retained within the uterus, usually the placenta, and they have to have a D&C. Complete is when they have bleeding and the full products of conception is expelled. the uterus contracts and the cervix will then close after it has been released. Missed abortion, I kind of briefly spoke on this already. There's not a viable fetus. Sometimes you'll hear the word blighted ovum. So you'll have kind of just a fluid-filled sac. You can have incidents where the fetal pole does form, and so then they go back at 10, 12 weeks to do a second ultrasound, and then you just have a fluid-filled sac because that baby has passed and reabsorbed. So you have no viable fetus in the uterus. You're not going to have any bleeding. There's no symptoms of this pregnancy having changed. Other than, sometimes, you may have lessened pregnancy symptoms because those hormones are dropping. You'll have some brownness discharge, but they're not going to have really any other signs. Most of the time, it can be expelled spontaneously, but sometimes these types of pregnancies do require D&C, or they may even just be able to take a medication to help kind of induce that cramping, in like Cytotec or Pitocin. Usually if they're doing that, they'll have it done in the hospital. Sometimes physicians will do a Cytotec at home, but most of the time that's going to be something that's required to be done in the hospital. Recurrent pregnancy loss or habitual miscarriages are when you've had 3 or more pregnancies that have resulted in a miscarriage. Septic is when that pregnancy itself has become infectious. Sometimes maybe the water broke, maybe the pregnancy has an IUD in place. Maybe the woman had a miscarriage, or not had a miscarriage, but had a elective abortion, but still there's parts of the products of conception there, and now she has an infection. It's usually related to something, could be even related to an STI. Diagnosis and treatment, you're going to obtain the history and physical of the patient. You're going to do a physical exam to determine where the bleeding is coming from, because it could also be just related to maybe they have a cervical polyp and that can bleed, or if they have that history of a biopsy that's recent, that's opening up. You're also going to do some lab work. You're going to do a pregnancy test, urine and serum, HCG levels. HCG can be detected as early as 8 to 9 days after ovulation, because as soon as that baby starts to form, that egg and sperm go together, that HCG hormone starts to be developed in the blood. It should double every 48 hours if it's a viable pregnancy. So you want to get an early baseline so that way you can kind of follow that. And most doctors will have them come in every 48 hours to have lab work done if they're just kind of lightly spotting. Hemoglobin and hematocrit to determine how much blood loss may have occurred. Also, again, to get that baseline. They also may need to consider a type and cross if there is a hemorrhage or heavy bleeding going on. An ultrasound just to see if there is cardiac activity, or maybe it's early enough that they can see the fetal pole and yolk sac. If they scan and they think, oh, well, maybe there is a chance that it's still too early to tell the heartbeat, they may have them come back in a week after checking those HCG levels to repeat that ultrasound. So your expected treatments are going to be, you're going to educate your patient on what to expect. Sometimes, the best course of action is kind of to let nature take its course, let the body do what it's supposed to do, because that non-invasive procedure, non-invasive way of doing it, you're going to have less likely to have scarring in the uterus. You're going to have, if they don't have insurance, there's not going to be any cost. There are some risks. It's unpredictable and frightening, of course, for the patient. They may just want to know how long it's going to be, and you can't ever estimate how long it may take for your body to actually fully miscarry. Some people do choose to go ahead and have a D&C if their doctor does give that option. Surgical, again, is the D&C, the dilation and curettage, and that's where they dilate the cervix, and they use these little instruments that actually go in and kind of scrape along the lining of the uterus to remove whatever is there. There is medicinal therapies. You can do the Cytotec suppositories. that will help induce cramping, which will then help the body to release the products of conception. It is, just like a surgical procedure, you do need informed consent because it is, it is a medication. You're causing your body to have a miscarriage. They're going to do Tylenol and not ibuprofen for pain because that ibuprofen acts as a prostaglandin, and it's going to prolong the treatment. Emotional support. You want to make sure they have someone there that's going to be there with them. They're going to go through those grieving processes, fear, pain, and it can last for a while. They can develop depression afterwards, just like a full-term delivery. Also, there's cultural considerations. This is where you have to learn ways of saying things because not everyone has the same beliefs, and so it's very good to have education on what your patient's religious preferences are, or what their beliefs are, so that way when you give that support, you have a better idea of how to address those situations. So what are you going to do as a nurse? So you're going to have fear related to risk of pregnancy loss. So you're going to have that emotional support. They're going to have acute pain related to abdominal cramping secondary to the threatened abortion. So you're going to offer pain relief, analgesics. Fluid volume deficit related to excessive bleeding secondary to spontaneous abortion. So, they may just require fluid through an IV bag, or they may even require transfusions. So ectopic pregnancies, on page 295 in your book, it discusses what these are. So it's the implantation of the ovum in a site other than the endometrial lining of the uterus. So it can be anywhere. It can be in the ovary. It can be in the fallopian tube. It can be in those fimbria of the end of the fallopian tube. It can actually be in the abdomen. So implantation anywhere outside of that endometrial lining. Typically, it is where it is in the fallopian tube. That is where most ectopic pregnancies occur. Again, it can be also found in the cervix. I did not mention that one. It occurs in 20% of pregnancies. It does account for about 10% of the maternal deaths because they don't know that they're pregnant with an ectopic pregnancy. That baby grows too big, that fallopian tube ruptures, and the uterus and fallopian tube are so vascular they bleed to death. It is a non-viable pregnancy. There's no way to take that growing fetus out and implant it anywhere else. Most of the time, there are signs of pregnancy present. They're going to have no period, amenorrhea, breast tenderness, nausea. They'll even have those Chadwick signs where that bluish discoloration of the cervix. They'll have HCG present in the blood and urine. Their uterus will enlarge, but because of it doesn't have the baby in it, it's not going to grow like it typically should. Symptoms, they're going to have vaginal bleeding related to that uterus not having the baby, and so those hormone levels won't support that endometrium level. So what's going to happen is that vaginal bleeding is going to occur. That layer is going to start to slough because that baby is not inside the uterus. So you're going to have vaginal bleeding, some nausea and vomiting with pain. Severe abdominal pain, usually it's a sharp stabbing or tearing pain on one side or the other. It can radiate, but most of the time the pain is going to be on the side where the ectopic pregnancy is. Sometimes when you go in to do a vaginal exam, they're going to experience pain with that. There are some other causes of abdominal pain that can occur in pregnancy. They can still have an ovarian cyst occur, appendicitis, ovarian torsion, or even a UTI. Another thing that can occur is dizziness or fainting. When that embryo outgrows the space, the tube ruptures, and so that fallopian tube rupture can cause enough pain to make them faint and have referred shoulder pain. So sometimes if they come in complaining of pain in that upper right or left shoulder, depending on which side the pregnancy is in, that is a sign, and then they've had a positive pregnancy test, that is definitely a sign you need to definitely do further examination with an ultrasound to see where that pregnancy is. They can go into hypovolemic shock. If profuse internal hemorrhaging is occurring, that stomach is going to become rigid and tender, and it's going to be most commonly in a slow ectopic, something that's slowly bleeding. The HCG levels sometimes will be lower, and they should double every 48 hours for that first 3 to 6 weeks, but in an ectopic pregnancy, they have slow HCG increases, and it's due to a slow transport of that blastocyst. They can have a low hemoglobin and hematocrit related to the bleeding. So risk factors for an ectopic pregnancy: tubal damage from pelvic inflammatory disease, previous pelvic or tubal surgery, infertility treatments, endometriosis. Endometriosis. Endometriosis is an infection. Endometriosis is where that lining sloughs off and goes into other parts of the body. Previous ectopic pregnancies, presence of an IUD, high level of progesterone so that it slows that egg motility from the fallopian tube, congenital anomalies of the tube, smoking, and advanced maternal age can be a risk factor. So how do we treat an ectopic pregnancy? So we're going to find out when her last menstrual period was, get her history, do a pelvic exam, collect those lab tests, do an ultrasound. Management. Many ectopic pregnancies resolve on their own before diagnosis. So that, the egg does get fertilized, but then whatever reason, it will then reabsorb into the body, and so then you do not have a viable pregnancy. Surgery, you're going to have laparoscopic surgery. They may require blood replacement if they did have hemorrhaging occur. They will also need ROGAM, because if they are negative and baby is positive that's growing in there, then they can have that RH sensitivity going on, and so they would require the ROGAM. There are medicinal ways to help with an ectopic without having surgery. If you have ectopic that's caught pretty early, then they can use methotrexate. Methotrexate is actually a chemomedicine. It's an antineoplastic drug. It's a folic acid antagonist, so it is definitely dangerous to pregnancy, but in this situation, this will help basically cause that ectopic pregnancy to reabsorb on its own and decrease that mom's need for any kind of surgical intervention, because you don't want to cause any scarring, and hopefully be able to save the ovary and fallopian tube themselves. It's 86 to 90% efficient. So the half-life of it is 8 to 15 hours. And sometimes they may need a second dose if the HCG doesn't decrease more than by at least 15% on day 4 to 7. So it just basically causes that pregnancy to just kind of stop growing, and then it just reabsorbs into the body. Gestational trophoblastic disease or molar pregnancy or hydatiform mole, on page 297 in your textbook, it talks about this problem. It's a placental related tumor. There's rapid formation of the trophoblastic cells. So the placenta has hydropic grape-like clusters that form, and they're fluid filled, and so there's no viable fetus there. Hydatiform mole is what it's also called, or molar pregnancy. It can be a complete or partial. A complete, you have an empty egg and no maternal genetic material is fertilized. A partial, you have the triploid karyotype, meaning 69 chromosomes. So the normal ovum has 23, and when it's fertilized with the sperm, you have 46, but what happens is you have two sperm or one sperm that maybe has too many chromosomes, like two heads, and so causes that there to be too many. Sometimes you may have identifiable fetal parts that could be there. Could have been a twin pregnancy where you have one normal baby and then one molar pregnancy. It occurs 1 in 1,000 pregnancies. Usually it's like really young females, less than 15, or could be 45 years of age or older. You know, but not always. It can occur really at any point. You're at higher risk if you had a previous molar pregnancy, and it is most often seen in Southeast Asian descents. So what is the assessment of a person that comes in with a molar pregnancy? So they're going to have vaginal bleeding, but it's going to be like a dark brown prune juice color. Anemic. They could even be passing those fluid-filled balls, those hydropic vesicles. They're going to have uterine enlargement, but it's going to be larger than expected. There's not going to be any fetal heart tones. They're going to have a really high HCG, a low alpha fetal protein. A lot of times these women suffer from hyperemesis gravidarum due to the related high amounts of hormones that are going on in the body at that time. They are at higher risk of preeclampsia and hyperthyroidism due to production of the thyrotropin by the molar tissue. What are we going to do for this mom who comes in with a molar pregnancy? So they're going to have surgery or a suction DNC. You're going to monitor for blood loss. Sometimes you do have to give oxytocin after the removal of the mole. There should not be any stimulation of the uterine contraction prior to removal or during removal. It can cause trophoblastic tissue to be engulfed into a large venous sinusoids of the uterus, sending an embolus to the lungs. So you don't want to cause contraction. So that's why you're going to do a surgical procedure. Monitor their kidney function, urine output, hemorrhage, symptoms of infection. If they need to have the RH or RhoGAM for RH immunization, then you need to do that. Grief counseling, because even though, you know, in most of these situations, it's just a clump of cells, it's those vesicles, even though there may have been formation of some parts, that person is going to grieve the loss of that pregnancy and the what ifs of, you know, that pregnancy. HCG levels weekly until they're back to normal. And then every 2 to 4 weeks for 6 to 12 months. With these hydatiform moles or molar pregnancies, you run a high risk of what's called choriocarcinoma. It's a cancer that is caused by these the trophoblastic tissue that can develop, and 20% of women develop this after a molar pregnancy. You're going to get a baseline chest x-ray as well to check for the metastasis, and then you're going to do a repeat chest x-ray if needed. So these moles can sometimes form that choriocarcinoma, and I actually have seen cases of this. It's not very common, but it can occur. Birth control is definitely an important part of that hydatiform mole. You want to make sure that a woman does stay on birth control for the first year after she does not want to get pregnant, because you're going to be following those HCG levels, because if they start to increase again, it could be a sign of that cancer. So cervical insufficiency, also known as an incompetent cervix, it does talk about it in chapter 20 on page 416. We do cover it here just because we do talk about miscarriage, and this is a common cause of late-term miscarriages. It's a painless cervical dilation without any contractions. Usually the cervix has structural or functional defect. It's typically discovered when a woman has a history of miscarriage. So what can be a cause of this cervical insufficiency? So maybe they were on a synthetic estrogen. They could have a bicornuate uterus or a malformation in the uterus and cervix itself. Trauma or biopsy, like a LEEP procedure where they removed a cone biopsy surgically or with the LEEP machine, and that cervix is half the size it would have been. Maybe they have an infection or inflammation related to an STI. A history of elective abortions because of the trauma that it causes to the cervix itself. Increased uterine volume, so maybe more than one baby, or even uterine fibroids can cause that cervix to dilate sooner than later because you've got those fibroids taking up more room in the uterus. So what are treatments for this? So you're going to do a vaginal ultrasound, bed rest to try to keep that gravity from doing its job. Progesterone supplements sometimes will help just to cause that cervix to stop dilating. Antibiotics or anti-inflammatory meds to reduce swelling in that area. And then you have the cerclage, which is a surgical treatment. So there's a purse string suture that is inserted into the cervix to prevent preterm cervical dilation and spontaneous abortion or the premature birth. And this is something that usually is done in the hospital setting. It's placed late in the first trimester or early in the second trimester, and it has a pretty high success rate. Usually they remove it at 36 to 37 weeks to allow then hopefully the woman to just go into natural labor on her own. So next we're going to talk about hyperemesis gravidarum. On page 298 in your book, it talks about hyperemesis. So a lot of women experience nausea and vomiting, but hyperemesis gravidarum is excessive nausea and vomiting, and usually most women who do have this, it does not fully resolve before delivery. So you have nausea and vomiting severe enough to cause dehydration and nutritional compromise. Lose 5% of their pre-pregnancy weight, so they definitely do not even gain weight. They tend to lose way less than what they did when they first got pregnant. What are the causes we think? HCG levels elevated, so if you got a multi-gestation, twins, triplets, high levels of estradiol or low levels of prolactin, just displacement of the GI tract due to that baby growing, hypofunction of the anterior pituitary gland and adrenal cortex, corpus luteum abnormalities, H. pylori, Helicobacter pylori can be a cause, or psychological factors. Sometimes it can just kind of be brought on itself by the mother's own thinking. So what are going to do for these moms? So, you're going to do an ultrasound to rule out the molar pregnancy because if they have those higher levels of hormones, it's going to cause that nausea and vomiting. So that could definitely be related to a molar pregnancy. You're going to put them NPO, IV fluids. You're not going to give dextrose fluids prior to thiamine correction, as it may cause Wernicke encephalopathy or loss of memory or confusion. You're usually going to do potassium supplements. Severe cases involve dehydration, and it leads to fluid and electrolyte imbalances and alkalosis. So they're going to have, they're going to need potassium. So it's going to be severe hypokalemia that leads to kidney inability to concentrate urine and interrupts the heart function. So you know how our bodies need that potassium for muscle use. Well, our heart's a muscle. And thiamine replacement, patient may have muscle wasting due to starvation. You're going to monitor the urine output. You want at least 1,000 mLs every 24 hours. You're going to monitor for hypovolemia due to dehydration, and that causes that blood pressure to decrease. You're going to have an increased heart rate, increased hematocrit and BUN related to that concentration of blood because of the decreased fluids. Control of nausea and vomiting, usually they're going to receive medications like Phenergan, Reglan, Zofran. Ginger is an alternative therapy, sometimes even acupuncture or acupressure, hypnosis. I've even had a patient in the past who had a continuous pump for Zofran that she wore 24 hours a day, and had home health that came in and changed it every so many days because, you know, once it ran out, she would start to feel sick again, and she wore it through her whole pregnancy. She got it when she was about 12 weeks, and we realized that she had the hyperemesis, that it, you know, she was kind of past that first trimester. And so she actually gained about 10 pounds in pregnancy once she got on it, and then was able to eat. She still suffered some with nausea and vomiting, but definitely not anything as bad. So, you know, after, you know, they kind of seem to be getting better, you're going to gradually begin adding foods. You're going to encourage frequent small meals. If you're unable to control the nausea and vomiting, they may even need a feeding tube down the nose just to be able to get supplemental nutrition for that baby and mom. So let's look at some questions here. So which assessment finding indicates that a client who is 10 weeks gestation may have a hydatiform mole? A, complaint of frequent mild nausea. B, baseline blood pressure of 120/80. C, history of bright red spotting for 1 day and 2 weeks, for 1 day for about 2 weeks ago. Or fungal at the umbilicus. So our answer is going to be D. You're going to have a uterus that is oversized for the gestational age that she is. A 24-year-old client has the following history. First pregnancy ended with a preterm birth at 21 weeks. Second pregnancy ended with a miscarriage at 16 weeks. Third pregnancy ended with a miscarriage at 13 weeks. What additional history indicates the possible diagnosis of incompetent cervix? Client had a pelvic infection between the first and second pregnancies. Client took birth control pills for 2 years before the first pregnancy. C, client had a cervical biopsy before the first pregnancy. Or D, client used alcohol heavily during her years in college. So C, client had a cervical biopsy before her first pregnancy, because we know that that causes that cervix to have weakness in it. A 28-year-old prima gravida is admitted to the antepartum unit with diagnosis of hyperemesis gravidarum. What is the initial nursing care that should be implemented for the client? A, refer the client to psychosocial counselor. B, isolate the client to prevent spread of infection. C, assess the client for signs of dehydration and electrolyte imbalance. Or D, provide the client with crackers to decrease the occurrence of morning sickness. It's going to be C, because we know with hyperemesis gravidarum, they're most likely going to be super dehydrated and have that potassium decrease due to the dehydration. So let's look at some hypertensive disorders that can occur in pregnancy. So you've got 4 categories. You've got chronic hypertension, preeclampsia, eclampsia, chronic hypertension with superimposed preeclampsia, and then you have gestational hypertension. HELLP syndrome is also in here, and it may or may not be associated with elevated blood pressures, but it can definitely occur. I've known of people who've had preeclampsia, turned it into eclampsia, and then developed HELLP syndrome. So if you look on page 299 in your textbook, it talks about these different categories in a chart there. So what are we going to do? We're going to obtain reliable blood pressures, resting, sitting with both feet on the floor in a semi-Fowler position, correct cuff size, and you're going to measure twice. And please, if you get a high blood pressure with an automatic machine, please, please, please get a manual reading. It is more accurate, the most accurate way of diagnosing gestational hypertension. Statistics say that the #1 cause of preterm deliveries are due to hypertension disorders, about 42%. It's the #1 indication for induction, which is about 25%. And it's the #3 cause of maternal mortality, 20% of direct maternal deaths and 50 to 100 near misses with every death. 20% reason of all NICU admissions is related to some sort of hypertension in pregnancy, and it's usually due to preterm delivery. Chronic hypertension. So you're going to have detection before pregnancy or prior to 20 weeks. So it's going to be a woman who comes in and she has high blood pressures pretty much from the get-go. So you're going to have a systolic greater than 140 and your diastolic greater than 90. Diastolic with 2 resting measurements separated by about 2 hours. So you want to have, double check them. BP 140 or 90 or more prior to pregnancy can be an indication. BP 140 over 90 or more prior to 20 weeks gestation, or BP 140 over 90 persisting 42 days postpartum. So some of those moms that come in and continue to have that hypertension post-delivery. There's no proteinuria, no other severe symptoms. You don't have any of the swelling, any abnormal lab work, nothing like that going on. So medication is used when your blood pressure is usually 160 over 105. And below that, most of the time, doctors just kind of monitor and manage it with, diet, exercise, and relaxation, resting. Methyldopa, nifedipine, labetalol are the first drugs of choice. You want to assess for a history of asthma prior to administering labetalol, as it is contraindicated. No ACE inhibitors are given in the 2nd or 3rd trimester. Fetal risk of renal failure, IUGR, and death can occur in the ACE inhibitors. You're going to have more frequent prenatal visits, about every 2 to 3 weeks, in the 1st trimester and 2nd trimester, and then weekly until delivery. They're going to monitor your diet, weight gain, and your sodium will be limited in your diet. Preeclampsia. So characteristics of preeclampsia are going to be a syndrome, it's a syndrome of maternal vascular dysfunction that can occur in pregnancy. So your clinical characteristics are going to be an increase in BP after 20 weeks gestation when they've previously been normotensive, so 140s to 160s over 90s to 110. You're going to see proteinuria in a 24-hour urine is going to be greater than 300. Your PC ratio will be greater or equal to 0.30, or you're going to have 1 to 2 plus dipstick. And now ACOG pretty much says 2 plus 1. It's kind of questionable. End organ disease can occur. You can have pulmonary edema and seizures, decreased kidney function, so you're going to have oliguria, so urine output's going to be decreased. Progresses throughout the pregnancy. Usually is reversible postpartum, so pretty much as soon as that baby is born, it stops. There's really no reason or cause known for preeclampsia. The one suspicion is that it has to do with placental factors and maternal adaptation. 2-stage disease, so you have stage 1, the placenta has pleural implantation, you've got hypoxia and inflammation occurring. When the previous stages exist, then it leads to stage 2, which is maternal. So you've got the chronic hypertension, edema, proteinuria, and you don't always have to have the protein anymore to be considered preeclamptic. If hypertension and other severe features are present, then you can still be considered preeclamptic. There's not really any gold standard tests anymore. We kind of have the ideas of symptoms and just go by those. Terms such as PIH or mild preeclampsia are discouraged, so we're not, you don't want to use those. You want to, if it's preeclampsia, it's preeclampsia. There's no mild, moderate, severe, unless they're eclamptic, and then that's severe. The etiology can be related to poor maternal vascular health, diabetes. That's why we see a higher risk for diabetic moms. Immunological risk factors, placental issues, maybe there's more than one baby, so that causes more pressure issues. High drops or a molar pregnancy, high altitude can be a cause, genetic predisposition, and this is true. You can see a family history. If a woman says her mother had a history of preeclampsia, then you definitely need to make sure that you know that. Also, if a father has multiple partners, and one wife had preeclampsia and then another girlfriend had preeclampsia, that can also be an indicator that that dad is kind of like a carrier. Um, so that has been noted. So chronic hypertension with superimposed preeclampsia. So you have a woman who was chronically hypertensive and now she's developed preeclampsia. So new proteinuria after 20 weeks, or chronic proteinuria with worsening hypertension. Exacerbation of the hypertension, you have sudden elevation in the liver function test. That platelet count is low. You've got thrombocytopenia going on. They're having liver pain, that right upper quadrant pain. They have pulmonary edema, renal insufficiency. Those BUN and creatinine levels are out of whack. They're complaining of severe headaches. It's more difficult to diagnose because you've got that history of the hypertension. For example, a woman has chronic hypertension but complains of a headache and vision changes, that has a history of migraines with vision changes. Is it superimposed preeclampsia? Probably going to be diagnosed because she warrants watching. So you're going to just definitely keep an eye on her. So eclampsia is basically when the woman who had preeclampsia develops seizures. So that is eclampsia. It can occur antepartum, intrapartum, and postpartum. Gestational hypertension, also known as pregnancy-induced hypertension or PIH. This is where the BP is greater than or equal to 140 systolic or greater than or equal to 90 diastolic after 20 weeks. No other manifestations of preeclampsia, so there's no proteinuria, no other severe symptoms. That BP returns to normal after 12 weeks postpartum. So next we have gestational hypertension. Gestational hypertension, we talked about this already, so we'll move on. So next we have HELLP syndrome. So HELLP syndrome is has a meaning. So it's hemolysis, elevated liver enzymes, low platelet count. So it is usually associated with preeclampsia in those more severe cases. So your hemolysis is the RBCs are distorted or fragmented during the passage through the small damaged vessels, and they result as a result of the vasospasms that occur. Your elevated liver enzymes, the blood flow is obstructed because of the fibrin deposits. It leads to an increased hepatic pressure, which causes liver swelling. So that liver distension can cause epigastric pain and can actually go as far as rupture. You may also see hyperbilirubinemia and jaundice. The low platelet count, so you've got less than 100,000. Those platelets aggregate to the damaged side of the vessel, causing low platelet counts, and it may or may not be associated with a high blood pressure, but HELLP syndrome and preeclampsia can go hand in hand. So what complications do we see of these hypertensive disorders? So you have central nervous system changes. They're going to have hyperreflexia, headaches, eclamptic seizures, intracranial or intracerebral hemorrhage. It's the most common cause of death, where you just have that such increased pressure in the brain that causes it to bleed. Increased intraocular pressure. That's when those women complain about the headache that's right there above the eyes. It can cause a detached retina. You can have kidney tubular necrosis, thrombocytopenia, hematoma of the liver, or even rupture. The only treatment for most of the hypertensive disorders are delivery, and ideally you want to do vaginal if possible. So what risk do we have to this baby? So we have placental insufficiency, so we've got fetal hypoxia in labor. Premature birth, need to administer steroids if greater than 34 weeks. This will help to develop those lungs. Intrauterine growth restrictions, you're going to have a small for gestational age baby or IUGR going on, and that's related to fetal hypoxia and malnutrition over the course of that pregnancy. So that woman who has that chronic hypertension or preeclampsia 20 weeks and on, that baby is not getting the sufficient amount of blood flow to that placenta. So you can have fetal oversedation at birth or fetal hypermagnesia because of the mom being on that MAG. So what are some treatments that we have? So if you have a woman who has the chronic hypertension or maybe some borderline pressures, they can be treated at home. You're going to monitor the blood pressure, make sure it's staying below 150 over 100. Monitor that proteinuria. Most of the time they're going to come to the office once a week to have that check. They're going to have recurrent CBCs done to check those platelet counts. They're probably going to have biophysical profiles, NSTs, monitoring their weight gain and monitoring that fetal growth with that biophysical profile, and just checking that placenta. They may require hospitalization. With the hospitalization, they're going to have bed rest on that left lateral position because you want to make sure that she is got full flow through those major vessels. A balanced diet with a low sodium diet. You're going to continue those fetal tests, NST, ultrasounds, that biophysical profile. They're going to possibly do an amnio when she gets closer to term to determine the LS ratio to see if baby's mature enough to go ahead with delivery. Maternal tests are going to be monitoring the blood pressure, daily weight, urine proteins, and labs. You know, if a woman develops that preeclampsia, you want to deliver. That's the idea. The only known cure is birth of that baby. And usually you're going to see a very rapid improvement, 24 to 48 hours. You're going to see changes, but they still can be at risk for seizures up to 48 hours postpartum. And you're still going to monitor those blood pressures more often post-delivery than just a normal vaginal delivery or C-section. And sometimes they may even be hospitalized until that blood pressure is normalized for 24 hours and then can go home. And you're going to see that more with like the chronic hypertension more so than preeclampsia. Usually once they hit preeclampsia, the goal is, to monitor that baby, get betamethasone and then get baby delivered once they've had their treatments. So betamethasone, it's given to mature those fetal lungs. It's a corticosteroid. They're usually going to get 12 milligrams IM one time, and then it's going to be repeated again in 24 hours if mom is not delivered. Dexamethasone is given for HELLP syndrome, so it's a higher potency than that betamethasone. The other medication you're going to see used when you have preeclampsia is that mag sulfate. It is a CNS depressant, so it decreases the quantity of acetylcholine released by the motor nerve impulses, and it blocks those neuromuscular transmissions. So we're reducing the possibility of convulsions. We're not decreasing the blood pressure, but because the way it does work, you will see most likely a decrease in blood pressure. So it's not considered an antihypertensive, but because of the way it works and helps those muscles to relax, you'll see a decrease. It relaxes the smooth muscles, so it's an antagonist to that oxytocin you're given. So that uterus we're trying to make contract, but then we're giving her MAG to make her muscles relax. So, you definitely kind of are playing a game there when you're giving both. So our goal in the end is to get that baby out. So, these women sometimes require those high dose Pitocin inductions. So, on page 572, there's a protocol for mag sulfate. It's important to read this and be familiar with it because we will be having a high-risk sim lab in November, and you may see these numbers again. So your loading dose is going to be about 4 to 6 grams over 20 to 30 minutes, and it just depends on your provider's orders. Your maintenance dose is going to be 2 to 3 grams per hour. So their therapeutic level is going to be way higher, so you're going to get that critical lab call. But that's okay. We want it to be high. We want it to be between 4 to 8 milligrams per deciliter, and that lab should be drawn about every 6 to 8 hours, and sometimes even every 4 hours. It just depends on your protocol at your facility. You're going to monitor that mother's respiratory rate. Her blood pressure should be monitored every 10 to 15 minutes. You're going to continue those MAG levels. You're going to check her reflexes and her output. Output is monitored every hour. You want to see usually 20 or more cc's of urine every hour. Sometimes the orders state 30, depends on your facility orders. You're monitoring for that MAG toxicity, okay? So with MAG toxicity, what are we going to see? We're going to see those reflexes disappear when the level of MAG is at 9 to 13 milligrams per deciliter. You're going to have respiratory depression at 14 milligrams per deciliter, and you can have cardiac arrest if it gets as high as 30 milligrams per deciliter. So what do we need at the bedside? Calcium gluconate. You can give 1 gram over 3 minutes. Because of that MAG, when that baby's born, you may have some respiratory depression going on, because just like with mom's muscular relaxation, baby's going to have the same thing going on. So how do we care for her postpartum? So most of the time you're going to continue those that MAG for 24 hours to help continue to reduce that risk for seizure activity, because you have that risk of seizures up to 48 hours. You're going to continue to monitor your lab work, your hemoglobin, hematocrit, platelets, uric acid, liver functions. You're going to monitor her vaginal bleeding, because remember, we've given her MAG that relaxes the muscle, and that uterus isn't going to want to contract as well. You want to monitor for postpartum depression, because MAG makes a mom feel very droopy, sleepy. They get hot flashes, and so because when you add that decrease of hormone, that quick drop, and the way they already feel due to the MAG, they can definitely have a higher risk of depression sooner than later. You're going to watch that baby, because mom's not going to feel well. She's not going to want to help care for that baby as well. So you want to make sure she has good support from family, a good support person. If not, you may have to look at how can staff help until mom feels better. Next, we're going to look at DIC, disseminated intravascular coagulation. So it is a complication that may occur in pregnancy with preeclampsia, abrupto placenta, intrauterine fetal demise, amniotic fluid embolism, maternal liver disease, or septic abortions. So the normal clotting process is overactive. So those fibrin clots get deposited into those microcirculation. The cellular tissue is then damaged. Further coagulation is triggered, depleting clotting factors. So they all gather in one place, and then they don't have anywhere else. So they then begin to hemorrhage and go into shock. If you look at page 307 in your book, it gives you more information about the DIC. So let's look at some practice questions. So the nurse identifies the following assessment findings on a client with preeclampsia. BP 158 over 100. Urinary output is 50 milliliters per hour. Lungs are clear to osculation. Urine protein is 1+ on dipstick, and edema of the hands, ankles, and feet are noted. On the next hourly assessment, which new assessment finding indicates that preeclampsia is worsening? A, blood pressure 158 over 104. B, urinary output 20 mLs per hour. C, reflexes 2+. Or D, platelet count 150,000. It is B. Your urinary output has decreased. So our blood pressure stayed the same, our reflexes are okay, and our platelets are okay. So that urinary output below 30 has definitely changed, and that's going to be a sign that we've got some other issues going on. A client diagnosed, A client diagnosed with DIC has delivered at 38 weeks gestation. Which is the priority nursing intervention for the nurse providing postpartum care to this client? A, elevate the affected extremity. B, assess for postpartum hemorrhage. C, replace fluid loss from the massive diaphoresis. D, continue teaching the client how to give her own heparin injections. And your answer is B. You're going to assess for postpartum hemorrhage because her clotting factors have decreased and she is going to be at risk for postpartum hemorrhage. So let's look at perinatal infections. So this could be related to different things. If you look at page 307 in your book, it talks about these. So you have fetal infection. So when is the most critical time for harm to the fetus if it is exposed to infection? So it's in that first trimester when those organs are developing. And how does an infection hinder the fetus later in pregnancy? Then you can have IUGR, preterm delivery, or neurovascular issues. TORCH. TORCH is a good acronym for the other ones you have, your toxoplasmosis, rubella, and cytomegalovirus. And then that is just can be used to help you try to remember the different infections that can occur. So you have toxoplasmosis. If contracted during pregnancy, it can cause long-term effects to that child. So it can cross that placenta barrier. It's contracted through raw or undercooked foods, unpasteurized goat's milk, or cat feces, like the litter box, or if they're working in the garden, or sandboxes. So first trimester contamination results in damage to the fetus and can cause spontaneous abortion. So your treatment is to educate the patient on diet and avoid cat feces. Rubella, the greatest risk to the fetus is in the first trimester. After 20 weeks, defects are rare. Most common clinical issue to the newborn is congenital cataracts, deafness, congenital heart defects, mental retardation, or cerebral palsy. If born with congenital rubella, the infant is infectious and should be put in isolation. For mom, the titer should be drawn, and it should be 1 out of 18 or greater is immune. 1 out of 8 indicates susceptibility. So the vaccine is a live virus, so it cannot be given in pregnancy. So this is when you would try to immunize mom prior to discharge from the hospital, because her being immune is going to decrease her risk of contracting rubella, and so that will decrease the chance the baby will receive it. It's also good to just have family members, along with the Tdap and other vaccinations like flu, have them make sure that they are caught up and don't need boosters or a shot. Cytomegalovirus, it's a herpes simplex virus. It's found in urine, saliva, cervical mucus, semen, and breast milk. It's passed between humans by contact, so kissing, breastfeeding, sex. It can be fatal to the fetus. So congenital CMV is the leading cause of hearing loss in most children, and there's not any treatment for this virus. Herpes simplex is the H of torch. Its risk to fetus varies. It could be it's dependent on whether or not they're exposed to the lesions at birth. If a mom has an active case of herpes simplex at the time, C-section is definitely going to be ordered by the provider. An infected infant will develop vesicular skin lesions, respiratory distress, fever, seizures, poor feeding up to 4 weeks following delivery. CNS symptoms can occur in the 2nd or 3rd week. If born with neonatal herpes, the infant should be treated with acyclovir. And this is a recent one we've seen where we've actually seen cases of babies dying from being exposed to herpes. So, it's not just that vaginal delivery exposure. We also need to educate our patients about making sure that they don't kiss a baby on its mouth or on its hands, due to the fact if you have, cold sores, that is a herpes simplex virus that can be contracted to baby and be very deadly. Group B strep, a mom is screened about 35 to 37 weeks gestation. This is a bacteria that is found in a lower GI or urogenital tract. It's transmitted to the fetus in utero or during childbirth. It is the leading cause of neonatal sepsis and mortality. So what they do if mom tests positive, they give antibiotics prophylactically in labor once mom has the ruptured membranes to help hopefully prevent that infection to baby. Other infections can also be UTIs, vaginal infections, and definitely STIs. They can cause issues with the pregnancy, can cause miscarriage, and also cause issues with baby once they're born if they're exposed. So trauma in pregnancy. So what are some things that we see that can cause trauma in pregnancy? We've got motor vehicle accidents, falls, and domestic violence. Trauma can cause complications in pregnancy and can even result in maternal or fetal death. So falls are results of balance or coordination or incoordination because of that big belly. Standing on a ladder or chair while painting the nursery, or walking and not being able to see the ground right below you so you miss a step. So just a mom being extra cautious whenever she's pregnant. Usually that baby is well protected if mom falls due to the amniotic fluid and the muscle layer, but it can cause mom to be at risk of developing that abruptoplacenta, and so they definitely would need to go in and be monitored and seen. Blunt trauma may occur, and maternal mortality often results from head trauma or hemorrhage. Uterine rupture is definitely a possibility if you have the abdominal pressure related to like a motor vehicle accident or maybe a very high fall. If you have that trauma to the belly, then you definitely can have that uterine rupture or even abruptoplacenta occur, which can result in maternal and fetal mortality. It could also maybe cause her to go into preterm labor if she, her water breaks due to the trauma. Life-saving measures are always implemented. You're going to do IV fluids, O2, fetal heart monitor, possible, surgery. And if the baby is near term, they may even be taken by C-section. This is when you have some of those ethical issues come into play, because if you have a mom who is severely injured, an ER physician's first patient is always mother, and so you have ethical decisions that have to be made sometimes at this point when you have a trauma like a motor vehicle accident, that if they can save mom and maybe have to lose baby, sometimes those choices have to be made. If there's no life threatened for mom, then external fetal monitoring for baby should be done for at least 4 hours to ensure that there's no contractions, bleeding, or uterine tenderness or leakage of amniotic fluid. If CPR is indicated for the pregnant woman, then a perimortem C-section is done if CPR is unsuccessful after 5 minutes. So if mom's had CPR performed on her, they're not able to revive her, then they may choose to go ahead and do a C-section to try to save baby. The C-section helps decrease the pressure of the inferior vena cava and improves resuscitation efforts for both mom and baby, so it can help mom also. So now we're going to look at our RH alloimmunization. So we have an RH positive mom, okay, or I'm sorry, RH positive baby and maybe an RH negative mom. So RH positive is present when on that cell surface. RH negative means they do not have that RH factor present. So they have the RBC antigens. You've got the C, D, and E. The D group usually is involved with incompatibility between the mother and fetus. So 6 out of every 1,000 live births are complicated by maternal desensitization to the D red cell antigen in the U.S. So sensitization means that the RH negative person exposed to the RH positive blood of baby, an antigen or antibody response occurs. Antibodies are formed and sensitization occurs. It can occur in that first trimester, so you can have fetal maternal hemorrhage, elective termination, spontaneous abortion, chorionic villus sampling can be done to check, and possible risk of ectopic pregnancy. When in doubt, always administer the RH immunoglobulin. We talked about, if you have a woman who comes in, fell, and she's having bleeding and she's RH negative, you don't know if it's related to placenta. And so if there's any risk that mom has been exposed to the RH positive blood type, you just go ahead and give that RhoGAM. So now we're going to look at sensitization continued. So you have the IgG and the IgM antibodies, okay? So IgM antibodies, after exposure to the positive antigen of that baby, the primary immune response is the IgM development. It develops slowly, detectable titer at 5 to 16 weeks after sensitization. They are large and they do not cross the placenta. Once they've developed, they're immunized for life, okay? IgG antibodies, a secondary response after a subsequent exposure to the RHD cells, causes a more rapid production of the IgG antibodies. Exposures can be very small. These antibodies developed as quickly as a few days after exposure, produce a stronger response than the primary response of the IgM antibodies. IgG antibodies do cross the placenta. They coat the fetal RHD positive RBCs, causing hemolysis. These are the antibodies that are a problem in subsequent pregnancies following that first exposure. So what are the fetal risks with this RH sensitization? No maternal risk. The fetal, there's a risk of hemolysis in the fetus that's caused by that IgG antibody creates a fetal anemia. It's a secondary response. Erythroblastosis fetalis is a severe hemolytic syndrome, anemia caused by hemolysis of the RBCs. This causes fetus to respond by increasing RBC production, causing erythroblastosis fetalis. And so it's that severe destruction of the RBCs. You can have hydrops fetalis. It's a severe fetal edema in the fetus. It occurs because of the erythroblastosis fetalis is not treated, and it leads to fetal CHF. And so these babies will be fluid filled. They'll just look very swollen, and they are incompatible with life. Hyperbilirubinemia occurs due to the RBC destruction. Jaundice develops. The buildup of the bilirubin can lead to neurological damage. So how do we screen? We get a history, maternal blood type, and RH. An antibody screen, the indirect Coombs test for sensitization. We repeat it at 28 weeks gestation. They're going to get the prophylactic RH immune globulin, which is that RhoGAM. And sometimes you can type the father. So if mom's negative and you're 100% that's dad and he's negative, then mom will not have to have RhoGAM. Interventions. So interventions for the sensitized mom, you're going to do antibody titers, amniotic fluid assessments, intrauterine ubilic transfusions. They may have to give blood transfusions to that baby through the umbilica. Various Doppler studies on baby. If negative antibody mothers, that fetus is not at risk. So if there's no antibodies there, that baby is good. So what is our therapy? So our therapy is RH immune globulin. We're going to give that RhoGAM. Okay, and there's a lot of other names that are out there. RhoGAM is the most common you'll hear. It tricks the body not to produce antibodies. Okay, so it works to destroy the fetal cells in the maternal circulation before sensitization occurs, blocking maternal antibody production. Provides temporary passive immunity for the mother, preventing the development of permanent active immunity, so that antibody formation. RH sensitization and hemolytic disease of the newborn are less common since the development of the RH IgG or the RH immunoglobulin. So you're going to give that RhoGAM. prophylactically at 28 weeks. It's also given after abortion, ectopic pregnancy, chorionic villi sampling, reduction of multiple fetuses, molar pregnancies, amniocentesis, the percutaneous umbilical blood sampling that can occur sometimes for certain babies, antepartum hemorrhage, fetal death, blunt trauma to the abdomen, or cephalic version. There is a Kleihare-Betke test. It's used for traumatic events as above, where a large portion of fetal blood may have entered the mom's circulation. How much fetal blood is in mom's circulation to calculate how much RhoGAM is needed. So this is actually, they do test most moms at Southwest Medical Center. They actually do this on all moms. And this, you can give up to 3 injections or 3 to 5 injections on some moms, depending on what that level is. So the normal dose of RhoGAM is 300 micrograms, but it can be up to 5 doses depending on what this test reveals. And you may be able to give it IV instead of IM if you're giving multiple injections. And if you read the vial of RhoGAM, it does say IV or IM administration. And so if you have a woman that you're having to give multiple doses to, and I would just give her IV RhoGAM. Postpartum, if no titer, so if we don't have a direct Coombs, and you have an Rh positive fetus, okay, then you're going to give 300 micrograms within 72 hours after birth. Woman does not have to have time to produce antibodies to fetal cells that enter her bloodstream when placenta is separated. If for some reason the dose was not given at 72 hours, then may be given up to 28 days post-delivery. So RhoGAM is like the cloaking device of Star Trek ship, the Enterprise. I don't know how many of you know what Star Trek is because you're all kind of young, but this is a show I watched as a kid. So Captain James T. Kirk employs the cloaking device to make the Enterprise invisible to the Klingons. The Klingons can't attack what they can't see, so future wars with the Klingon are thus avoided. As the Enterprise leaves the Klingon space, the cloaking device is no longer needed. So RhoGAM cloaks the Rh positive blood in the system of the Rh negative woman, making it invisible. Her Rh negative blood can't make antibodies to the Rh positive blood. The Rh positive blood eventually leaves her system, and it is like she was never exposed. So now we're going to talk about ABO incompatibility that can occur with mom and baby. So this is for type O moms with a type A or B positive fetus, okay? So mom has that type O, baby's type A or B. So anti-A and anti-B antibodies are naturally occurring through foods eaten, infections by gram-negative bacteria, can cause high serum cause of high serum anti-A and anti-B titers before pregnancy can be antibodies can cross the placenta, producing hemolysis of the fetal RBCs. First infant frequently is involved. So you're going to assess that newborn for jaundice. Okay, newborns usually only have mild anemia, and severity is limited to the firstborn infant. So you're not doing RhoGAM on these babies. You're just monitoring those babies because of that incompatibility. They're more likely to develop jaundice. Okay, so you're just going to watch those babies. So NCLEX questions. A pregnant client is admitted to the hospital with preeclampsia. Her blood pressure is 148 over 100, her urine protein is 2+, and she is pitting ankle edema. The physician orders mag sulfate intravenously. Which of the following medications would be the most important for the nurse to have available at the bedside? Epinephrine, Narcan, calcium gluconate, or diazepam? C, calcium gluconate. That is your antagonist for that mag sulfate. NCLEX prep. Question number 2. A client is admitted to the postpartum unit with a mag sulfate continuous IV drip for pregnancy-induced hypertension. She delivers a viable neonate by C-section. Which of the following immediate post-op orders would the nurse most likely question? Anzamet 12.5 milligrams IM now for nausea. Demerol 50 milligrams IM every 4 hours PRN for pain. Mag sulfate level 4 hours post-delivery, or discontinue the mag sulfate drip. D. You're going to continue that mag sulfate drip for 24 hours. NCLEX prep. Question 3. A 17-year-old nullipara reports to the clinic in the 24th week of gestation. Which of the following findings would indicate the need for further assessment by the nurse? A. Edema of the lower extremities at the end of the day. B. Presence of clear thin vaginal mucus. C. Blurred vision reported by the patient. Or D. Low backache. C. Could indicate PIH. So that blurred vision reported by the patient is definitely a sign of PIH. NCLEX prep question number 4. A 32-year-old prima gravida is admitted with a diagnosis of ectopic pregnancy. Nursing care is based on which of the following? A. A DNC will be performed to remove the products of conception. B. Bed rest and analgesics are recommended treatment. C. She will be unable to conceive in the future. Or D. The patient is high risk for hemorrhage. D. That patient is high risk for hemorrhage related to rupture of that tube if that baby continues to grow.